Hello, and thank you for joining me for today's episode of Big Ideas in Eating Disorders. In this series, we hear from people in the field of eating disorders who share with us their personal and professional reflections, journeys, their big ideas that never quite get represented in this way in standard academic conferences and publications. I'm Kathy Pike, clinical psychologist and professor at Columbia University, and I'm the host of Big Ideas in Eating Disorders. And today I'm delighted to be talking with Dr. Angela Guarda. Welcome, Angela.
Thank you, Kathy. Great to be here.
Dr. Guarda is the Stephen and Jean Robinson Professor of Eating Disorders and Professor of Psychiatry and Behavioral Sciences at Johns Hopkins School of Medicine. And Dr. Guarda is an active clinician, educator, researcher who directs the Eating Disorders program at Johns Hopkins Hospital. Angela, as we get started, I'm just wondering, you've been at this a long time. I don't know if you can remember back, but what might you have done if you hadn't gone into eating disorders? And when did you decide eating disorders was what you were going to do?
Well, it was not a straight line, I can say that. I was a biology major as an undergrad and really graduated from undergrad without a clear idea of what to do next. Although I had gone to Johns Hopkins, and since 60% of my class was pre-med, I kind of went along and did all the requirements, but didn't apply to med school, and decided to take some time off. And I'd become interested in psychology, taking some electives as a junior. So I registered for a master's in clinical psychology, but then decided I wanted to do more neuroscience. So I left that and worked for a year and a half at Hopkins as a research assistant with Joseph Coyle on excitatory amino acid neurotransmitters. And that pretty much convinced me that I didn't want to do bench work. So then I, again, kind of wasn't sure what to do, and then had this great idea I was going to apply to acupuncture school because I was kind of interested in, obviously in psychology and medicine, so in a holistic view of people. And as a child, our family doctor was a Romanian acupuncturist, which is another story. So I didn't get in. I was rejected because I asked too many questions about the mechanism of action at the interview and was told I should come back when I was more ready. At which point I kind of broke down and said, okay, I guess I'll apply early decision to med school. And I went to med school at Maryland, and I chose Maryland because it had a combined advanced track in psychiatry. And I was interested in the mind. And then from there, I did residency at Johns Hopkins in psychiatry. And as a resident, I rotated through eating disorders and didn't really think it was the right fit at the time. But I was lucky enough to get an internship for 6 months at the Maudsley. And one of the options I elected or asked for was eating disorders, and therefore I was placed with Janet Treasure, which was a wonderful experience, and also had the opportunity to meet Gerald Russell because he had just retired and was there part-time, and to also learn about family-based treatment by sitting in on some of the resident training that was being done at the time by Chris Dare and Ivan Eisler. Mm-hmm. And I should mention that our program here at Hopkins was actually started by our ex-chair, Paul McHugh, who was a close friend of Gerald Russell's and had visited Gerald's program in England. And therefore, and what happened is he actually got Arnold Anderson to start the program here at Hopkins, and Arnold had left the year before I arrived. So there was kind of a vacuum, a leadership vacuum in this program. And so when I finished my residency, I wanted to stay here and work, and Paul McHugh offered me a job in the eating disorders program. And I said, sure, I'll try it. It sounds good. It's turned out to be a really good fit. I've really enjoyed it. One of my worries at the time was, all the patients might be the same. And in reality, this really is such a diverse disorder, and, a very rewarding one, I think, because we are able to help a vast majority of patients to get better, and a significant proportion to get well. And that's really something that doesn't happen in all fields of psychiatry. So I finished training in 95 and really started running this program in 97.
So you might have been an acupuncturist, but you became a psychiatrist and got into eating disorders a bit by serendipity, but also it sounds like working with individuals who had eating disorders brought together a lot of the interests that you had about the mind, the body, the psychology,
I was also interested in nutrition. And I was interested in treating women. At the time, I had really been interested in borderline personality, postpartum mood disorders, or eating disorders. Those were kind of areas of interest, really, because I wanted to work with younger women. So it was a good fit. And the experience of spending 6 months at the Maudsley was extremely helpful, because when I came back here, I incorporated a lot of what I had seen there. I actually incorporated family meals on the inpatient unit because I had a sense of FBT. We started working with families for all patients, adults as well as adolescents. And, both the Maudsley program then and the program here were entirely meal-based. Really, most programs are using meals. However, many are using, increasingly, I think, in the US and probably internationally, we are seeing more use of nasogastric or enteral feeding. And what I mean by an exclusively meal-based program is we do not use tubes under any circumstances, but really are able to get nearly all patients, upwards of 98% of patients admitted to our program to gain weight with only food. But it's not just about food. For instance, some of the early programs primarily use nutritional supplements to get patients to gain weight. And one of the concerns in anorexia is what you see in patients is anxiety about eating, especially anxiety about eating high calorie density foods or adequate caloric intake. So one of the focuses of our work here has really been on helping patients to normalize their eating behavior. So to eat in social settings, to eat a balanced macronutrient meal content, to eat a high variety of foods across 3 daily meals, plus 1 or 2 snacks at the most, as opposed to using more liquid supplements, or certainly using enteral feeds, which, the problem with this behavioral approach is it's more staff intensive and it requires a specialty program. It's very hard to use a behavioral protocol with one patient, for instance, on an adolescent medicine unit. And that's because we are combining both a behavioral protocol that uses graduated steps with, and I'll describe those, with group therapy that is focused on generating recovery-oriented peer pressure to get patients to complete their meals. So, for instance, when patients are admitted to our program, they can't initially choose their food. And the reason for that is to help them to broaden their food choices, because oftentimes what we see in anorexia is a very restricted food repertoire, not just low calories consumed per day, but also very few types of foods. And so the way the protocol works is you can't choose your food for the first 10 or so days, but if you're completing your meals by that time, you start to choose from a menu. And then once patients are gaining weight appropriately, and our average rates of weight gain are over 4 pounds or close to 2 kilos a week, then patients are, depending on how close they are to a minimal healthy weight, will transition to the integrated partial hospital here. And in partial hospital, a lot of the focus is more on translating normal eating to the real world. So they will start eating off the unit, eating in restaurants, going to the cafeteria with nursing staff and selecting foods, getting carry out, preparing meals in the kitchen, the therapeutic kitchen we have, and then inviting family to eat with them and to learn the method of portioning foods or the exchange system that they've been taught. And then they'll go out with their family for a leave and eat at home, and then eventually taper out of the program and only be here a couple of days a week. So the goal is to help patients extinguish maladaptive eating behaviors and to overcome anxiety about eating a balanced range of foods, because these, we know, are important skills to recovery. It's not just about weight gain, it's also about normalizing eating behavior, and obviously about correcting cognitive distortions that sustain the behavior. But you can't really talk your way out of anorexia. At some level, you have to eat your way out too.
So you've got this comprehensive program that relies on the collective of the group, relies on really the strength of peers who are in recovery, relies on a skilled nursing staff and team, many layers, right? You mentioned
the team.
Nutrition, there's behavior, there's therapy and more cognitive behavioral therapy as patients are able to engage in that effectively. So you've got a lot going on. I appreciate your comment that it requires it takes time and it takes real knowledge. There's a real expertise around doing this work. But I wonder if we could move into this. You've quickly kind of zeroed into a patient group that you focus on at Hopkins, where you're really treating largely individuals who have anorexia nervosa or anorexia, in the range of anorexia nervosa disturbances in the most severe cases, right? The inpatient service and partial hospitalization. You've got a lot of experience with individuals who have really lived with this disorder for a while, have endured the suffering of anorexia nervosa for a long time. What language do you use? There's a lot of discussion about what language do you use. Is it severe and enduring anorexia nervosa? Is it chronic anorexia nervosa? And the latest terminology, the latest term that has entered our field has been this discussion about terminal anorexia nervosa. Can you talk for a minute about the language we use? And then I'd like to go into more specifically the newest vocabulary that's entered the field and what you think about it.
I think, there's a lot of power in words and in labels. And we have to be really careful about terminology, because it can either promote recovery or kind of in some ways foment illness and despair. And I think that, before talking about this new idea of terminal anorexia, I just want to concentrate on the terminology that we had before, which was really, well, I guess back in the day, it was more, there wasn't any terminology. We talked about maybe chronic or severe, and they're different because, of course, severity is judged based on acuity or how medically compromised or psychiatrically ill someone is, whereas chronicity is how long you've been sick. And obviously, the combination represents the most concerning population. Those who are extremely, for instance, in the case of anorexia, underweight, may also have multiple maladaptive eating behaviors, maybe not just restricting and exercise, but also purging or binging behaviors. And chronic, in terms of chronicity, some patients are ill for decades, but we don't have a good idea of who can get well. We know that we don't have good predictors of recovery. But in going back to the labels, one of the problems with some of the more recent labels, and I'll just focus on severe and enduring, is I actually prefer chronic, in the sense that chronic is the word that is used in medicine for most illnesses that are protracted, and it doesn't imply uncurable. Enduring always has sounded to me like harder to recover from than chronic in some ways. But this latest kind of proposal that there be a diagnosis called terminal anorexia, I think is extremely dangerous for a number of reasons.
So let me just punctuate that with a reference to the article by Dr. Guadiani and Alyssa Bogetz and Joel Yager, which is the article that catalyzed some of this, I think largely catalyzed this discussion around terminal anorexia. And if you could speak to, you made the comment that people can have chronic conditions that are not necessarily life-threatening, right? Have a chronic, mild case of eczema or asthma or something, right? That can be chronic but not life-threatening. In your view, what's the intent around establishing this? Why was terminal anorexia put forward from your perspective, and where does it fall short in terms of helping us in our work?
Well, my short answer is that I think that the only purpose for this diagnosis is to justify physician-assisted suicide, which I really feel is very dangerous territory for us to be in as treatment providers for anorexia, as a psychiatrist, as a physician. The proposed criteria that Doctors Guadiani and Yager have put forward for this diagnosis are that an individual has to have anorexia and has to be over age 30. So age 30 is actually pretty young. And the problem is that although it is true that if you're 30 and you still have anorexia, you're not in the early recovery group, the data that we have, the longitudinal data that we have on anorexia, supports that recovery can occur over the course of decades. For instance, there's a study from Mass General that followed patients over 20 years, and 2/3 eventually recover. But if you look at 9 or 10 years, only 1/3 is recovered. So that means that second third is recovering in the second decade. And 30 minus 20 is age 10. So if you develop anorexia at age 10 and you haven't recovered at age 20, you would qualify for this diagnosis. But we know that recovery can happen after that long an interval. The other thing, which I kind of alluded to, is we don't have any clear predictors of recovery. We cannot tell who will and who categorically won't recover. And we don't have anything like the staging criteria that, for instance, exist for most cancers that have some significant predictive validity, meaning, stage 4 cancer, some stage 4 cancers have an average prognosis of 3 months. So they would be closer to what you would define as a terminal, more clearly terminal condition. Whereas here, if you speak to most people like physicians like myself who work with this population, they would all tell you that they've had surprises in both directions. In other words, patients I've seen as teenagers who I thought had a mild case and remain ill 20 years later, and patients who are in their 40s, 50s, even 70s, who may have been admitted several times before, so have failed treatment, but who recover. Sometimes it's really a life event that is the tipping point or the turning point for them. I've had a patient come back recovered saying, well, my mother got cancer and I realized I had to stop. So I put into action everything I'd learned in prior treatments. Or getting pregnant sometimes has kind of changed someone's view and helped them to recover, or a relationship.
It makes me think, Angela, you use the term failed treatment, but in fact, when you really take a long-term view, the treatments that in shorthand, patients and family members and healthcare providers sometimes refer to as failed treatments are anything but failed treatments. They're part of this journey that gets people to on this course of recovery. And I often have spoken to patients who have been hospitalized multiple times, and they say, finally, my 5th hospitalization was finally the one, that worked for me. But they could never have gotten to number 5 without number 1, 2, 3, and 4. So it's really an important point that you make about actually access to care, engaging in care over time, and what it takes to get to be on a course of recovery, and recovery being this journey rather than a destination.
Kathy, I think you're making a really key point there. We know that reaching a healthy weight is the best predictor of recovery in anorexia, but that a significant proportion, up to 50%, relapse. But those patients, I believe, who make it to weight restoration are, as you point out, primed in a way to recover later. They won't all recover, but they know what they need to do. And you just reminded me of this patient I saw early in my career who was a teenager who we admitted 3 times, weight restored each time. She just promptly lost all the weight afterwards. And after the third time, her parents brought her back, and I said, I'm sorry, I don't know what else to do to help your daughter. I suggest you try a different program. Maybe a different program will help her to engage. And then I didn't hear from her for like 15 years. And one day she just called me up out of the blue. I actually didn't think she'd survive because she was very, very low weight when she was sick. And she called me up and said, oh, Dr. Guarda, can I come see you? I have a surprise. And I said, sure, I'd be happy to see you. It's so great to hear from you. And she comes, we arranged to meet. I open the door, and standing in front of me is a 25-year-old woman who's 8 months pregnant and looks perfectly healthy. And I said, how did you do it? What happened? I thought you would never recover. And she said, well, I didn't for many years, but at some point I started working with a therapist who actually knew nothing about eating disorders, but I connected with her. And I guess I just was at a point in my life where I decided I'd had enough of the anorexia. And so I pulled out, she said, my exchange forms, the meal exchange forms from Hopkins, and I started following them. I showed them to my therapist, and I just did it. And I said, wow, do you think you could have done it if you hadn't been here? Do you think you would have still gotten better? And she said, no, I think I had muscle memory, or whatever we want to call it. But because I had done it before 3 times, I kind of knew what I needed to do, and I was more ready to do it. And I think that's kind of the problem here, that we don't know what a failure of treatment really is. And so that brings me to kind of the second criterion that doctors Guadiani and Yager have for their terminal anorexia diagnosis. And that is that the patient has to have failed high quality multidisciplinary treatment, which is totally undefined. Meaning we, the experts, don't even fully know how to describe what that is. Different programs do slightly different things. They have slightly different behavioral and nutritional protocols. I do, when you talk to patients and ask them, well, what, I often ask patients, well, what were other places like? What was good? And what do you think is better or worse here? How can we improve? They often say, yeah, I did better in one place than the other because this piece of the protocol worked for me, and it's a different, not necessarily the same thing for each patient. So I think we can't easily define what that is. And a lot of it, as you pointed out earlier, depends on the expertise of the staff. It depends on the ability to form a therapeutic alliance with the patient. And that's kind of the key to recovery. But it's not something we can easily operationalize or describe. So I think that's really another problem with kind of defining what multidisciplinary good treatment is. And then, the final problem with treatment is access. Access to treatment, to expert multidisciplinary treatment for anorexia in the US or probably worldwide is extremely limited for this group of patients. We have done a pretty good job in my career of improving treatment for adolescents with anorexia. I mean, there has been a shift. Family-based treatment is much more accepted than it was when I started in this field. Putting parents in charge of refeeding an adolescent is recognized as the correct approach, at least a first-line approach. But we don't have a clear first-line approach other than weight restoration for those who are adults with chronic illness. And they don't have access. In fact, there's very little specialty care for adults. So most are being treated by either general psychiatrists, primary care physicians, or no one.
Right.
And that, it's hard to really say that someone has failed treatment when they don't have access to it. And that becomes a problem with the diagnosis in other ways.
So you've got, with the proposal by Dr. Guadiani and Yager, Dr. Yager, you've got the age criterion and having failed treatment, comprehensive treatment, and issues of access are a significant definition of what that is, and then access to that. Other aspects of the definition of terminal anorexia nervosa that you are concerned about?
Yeah, the third and last criterion is a clear and consistent expression by the individual who has to have decision-making capacity, that further treatment is futile, that they choose to stop treatment, and that they accept that death is the natural outcome of their illness. And the big problem with this criterion is the problem of capacity in anorexia, or the ability to make a reasoned decision in one specific area, and that is in the area of accepting or refusing treatment. Because ambivalence about treatment is essentially a cardinal characteristic of the disorder. And at some level, all patients struggle with accepting treatment, especially treatment that involves weight gain or change in eating behavior. Talk therapy is fine, but that is not going to usually get you well by itself. But patients do want treatment, but they kind of want it on their own terms without really changing their behavior very much. A lot like in addiction, this is a motivated behavior where part of you just wants to keep doing what you did yesterday. And whether that's exercise or restricting or whatever. So the issue of capacity in anorexia is subtle. It's very nuanced, because otherwise patients have capacity. They can reason in all other areas. But capacity requires several elements. It requires being able to understand the risks and benefits. And I think most patients with anorexia can do that. They understand that they have hypokalemia and that the risk is an arrhythmia. Or that, need to, the treatment involves weight gain. And they can list the risks and benefits of the choices. They can reason through the pros and cons, which is the second criterion of capacity of each choice. But what they struggle with is appreciating how those elements, risks and benefits or pros and cons, apply to their situation. For instance, that's why group therapy helps in inpatient settings, because the patients can say, well, I don't need to be here, but you need to be here. And, and it's like kind of being able to confront each other about the ways in which they distort justifying their behavior. That is what is therapeutic about group therapy for this disorder. And then the fourth criterion for capacity is to be able to communicate a reasoned, consistent choice. And the reality is in anorexia about this issue, about accepting treatment, the vast majority of the time, patients are of two minds. And you can even see that in the cases that are described in the article by Dr. Guadiani and Yager, in the sense that the patients, at least two out of the three, are clearly ambivalent, about whether they want treatment and whether they want to accept physician-assisted suicide, frankly.
Another facet in the conversation that comes to mind for me, talking with a former patient of mine, she said, who is now thriving, said that there were times in her life where she would meet the criteria for terminal anorexia. And she's now, a parent with kids and in a marriage and active in has a very full life. And so we've had and I have another patient who has come to me with a similar concern of reading what's the conversation that's been now put out in social media, and feeling incredibly demoralized about their chance of ever recovering. And are they just putting off what's the inevitable end because they are struggling? And so I wonder if you could speak to that concern from the patient perspective and what you're hearing patients on your unit about the impact in terms of the demoralization or the risk of contagion that could be part of having this conversation.
Yeah, this is another big concern, really, how patients will perceive the term. And the risk of social contagion and suicide is well documented. For instance, the media has rules about how they can portray suicides of public figures, because we know that following the suicides of well-known figures, actors or media figures, there is typically a spike in suicides. The other thing that we know is associated with increased suicides is our films or media that glamorizes suicide. For instance, 13 Reasons Why was a popular series that aired in the US a few years ago. It was about kids committing suicide, and there was a spike of suicides amongst adolescents following the screening of that series. So the problem with the terminology is that if patients start choosing to die this way with anorexia, other patients will read about it or learn about it because they may know the other individual and may be influenced in just the way you say. It may kind of invoke feelings of, oh my God, I've heard patients say, I'm a lifer, there's no hope for me. But as a physician, my role, I think, as a psychiatrist is to instill hope in recovery, or at least in improved quality of life, in a meaningful life. I mean, I think that's what psychiatrists do. They try to improve well-being, general well-being, and instead kind of giving a patient this diagnosis is kind of it's contradictory to my role as a physician. And for who do I decide it for when I don't even know which of my patients can recover, when or how? So the other issue with the patient perspective, I think, is that for some patients who are deep in their anorexia, there's an element of anorexia that involves comparison. Am I as sick as her? And we see that sometimes on an inpatient unit where patients, for instance, there's a anorexia is very closely tied to identity, and there is an element of it that's valued by the individual. It's like they see it sometimes as, well, I can do this and nobody else can, or I want to be better at it, even though they know it doesn't rationally make sense. But it is possible that for some patients, it may become a goal to be diagnosed with terminal anorexia. And that's equally worrisome.
So I think in terms of getting a sense of what's on your mind these days, and a big idea that you've got about our field, it's pretty clear. Big concerns about the way in which this conversation has progressed, and the potential to move forward with a terminology of terminal anorexia nervosa that, from your perspective, is fraught for all the reasons that you shared. Is that a fair reflection back of where you're coming from?
I think there's no place for this term in our field, in psychiatry in general. I think it's a problem for all of psychiatry. And, I think the existing safeguards are inadequate. And I actually worry that the cases described by the authors demonstrate some of the failings in the safeguards. There's no consistent requirement in U.S. states where this is legal for psychiatric evaluation. The palliative care expert in one of the cases described felt too uncomfortable to weigh in on an opinion about MAID, so they had to seek another physician. The problem of kind of doctor shopping to find someone who will agree, a physician who will agree, because two physicians are required to agree in the US that a patient is eligible for this procedure. But there are other issues. For instance, in Oregon or Washington or states where this is legal, the waiting time, you have to make two requests. The requests can be as little as 2 days apart or 2 weeks apart. The physicians can be physicians who have never taken care of you before. There is no requirement that they cannot speak to your family unless you give permission. So it is possible, for instance, for a patient to act on physician-assisted suicide without their family involvement based on current U.S. laws in states where this is legal. So there are many other issues that show how slippery the slope is and the risk of unnecessary deaths occurring. And that's especially true for this condition, where we really can help most patients if they have access to good care.
So the other side of what I'm hearing from you, Angela, is that we need to be talking about the part of the conversation that is silent here, which is, what are we doing about better access to care, safeguards, social determinants, and providing.
Right. We don't have in-home services, occupational therapy around meals is especially helpful for this population. There may be new treatments that, are currently in development or being researched, like neuromodulation, like TMS or direct current stimulation, even something like psilocybin, which, is really, at this point, there is not good data yet for, but there are possibly other interventions that will come up, that will be developed in the next few years that could be helpful. But this is not really helping us. This is actually hindering the options for treatment, I think, for this, very ill group who can get much better and many of whom can recover over the long term.
Angela, you have treated so many individuals who have gotten better over the long term. I want to thank you for your dedication to the field, the way you've helped us develop treatment programs and build the knowledge base that we have. And thanks for taking the time today to share your concerns about this direction, this conversation, and really help shape the conversation to move forward more constructively. Thanks.
Thanks, Kathy. It was a pleasure.